Hi, I'm Frances Ashgoin, member of the forum. Um, it's been going on in my mind listening to all the presentations that we've heard today, and so what I've gotten so far, and I'm trying to reflect on it, is that as you're becoming older, and as I become older, that there is a consequence of being older. And on one hand, the consequence is you get to be 107, look as old, as gorgeous as that woman looked, and it seems like all is well in her world. Or you get to go into a facility in which you don't want to go in a facility because you feel like you're isolated from your family, but your family's putting you there because they can't care for you. And then there's all the as a nurse, I worked in a nursing facility for a little while, a nursing home facility for a little while. And it was so sad because there were people that were there that didn't know why they were there. And it wasn't that they had cognitive dysfunction, it was just they felt sad that they couldn't stay in their own home or stay in their home with their family members because their family members' homes were not conducive to them living there. There are too many kids, there's no room, or that they just felt sad. And so they either acted out or became totally depressed. So, what do you see as a future for somebody that is approaching that age, or for somebody that's looking at their parents approaching that age? What are your suggestions from all the research that your institute has done as the best outcomes for these people?
It's a very good and tough question. And I don't know that the National Institute on Aging has the answer for you, so I'm just going to talk from my heart as a geriatrician, that yes, I've seen that same sort of thing and everything in between. Um, and I think that there are opportunities for people as they are younger to prepare for becoming older and frail and potentially dependent. Um, and it's a matter of what route you want to follow. Some people want to stay in their home for as long as they possibly can and don't prepare at all. And that's something that's really foolhardy because very few of us are lucky enough to just die in our sleep without having had any sort of decline. Um, some people will take advantage of long-term care insurance that would allow them to have services to come into the home so that they don't have to be placed in a long-term care facility. Some people are lucky enough to live in an environment where they have a more forward-thinking approach to long-term care, where there are greenhouse experiments, et cetera. And I've even had some patients that say, I am going to make that choice of going to such and such a nursing home because I don't want to be dependent upon my children. And it's been actually a good transition for them because it was something that they were ready to do. But it is an individual journey in each case. And all I can say is that as someone else who's also looking at my older parent and his failing and my kids being very busy and, what's going to happen to me, you just try your best to figure out what your likely health is going to be, what you need to do to prepare for yourself, and what you think your options, what would be best for you in terms of options. There's no one answer.
I want to follow that up. One of the previous presenters, Pamela Tester, you presented frameworks for this area. And one of the things that you said was that there was a model on caregiver stress and family stress, and that there are some concerns about that model because is viewed as blaming the victim. And I was interested in that comment because it seems like that's an important part of some of the issues related to elder abuse and maltreatment. And I'm just wondering about opportunities for research and also for service agencies in terms of the types of supports that families need in order to, because there are families who want to keep elder parents and family members in the family, but it's difficult. The services may not be there. The services are not comprehensive. There are issues in terms of what insurance will cover. It's fragmented, et cetera, et cetera. So I'm just wondering, I know from NIA perspective in terms of research, but also from service agencies, what are some of the things that we need to be looking at?
And I'll probably have to defer to Secretary Greenlee because her agency really takes a lead in providing services. But I would certainly say that, again, in my life as a geriatrician, what I would often do would be to turn to the area-wide aging agency or refer my patients and the patient's family to the area-wide aging agency to determine what services are available to them in the area and to take advantage from that standpoint. For the services themselves, we worked not only in terms of referring for services, but in doing assessment of what the needs were. That's a state-by-state, county-by-county sort of determination, because what's needed in Oklahoma, where I came from, is going to be very different from what's needed in Baltimore, et cetera. So, Secretary Greenlee, would you like to address this a bit?
I would just, thank you, Dr. Bernard. Good to see you again. I would just add a piece on, let me scoot up, family caregiving. We do have, and have had for about 12 years now, a National Family Caregiver Support Program through the Administration on Aging and the Older Americans Act. Family caregiving is a huge issue. And you can say several things about family caregiving that are all true, but all seem inconsistent. There are people who think families have stopped providing this care. I have had this experience in testifying at the state level when legislators were tired of paying for long-term care. It's like, where are the families? Well, families are and continue to be the major source of long-term care support for people in this country. And that hasn't changed. So it's still the foundation, and we don't want that to change. First of all, families love people more than the government does, just in terms of the daily support. You know, I mean, that's true. I mean, you want families to be there and love and concern. But we also have to figure out how to provide support so that the family can remain. My friend Dan Reingold's going to talk this afternoon or tomorrow about one of his innovative programs. But we have to focus on caregiving and what can we do to support family caregivers who very much do this burden of love to provide this care. But I also think, and this actually relates to one of my opening comments, that if we're going to be competent about talking about family caregiving, we should not assume that all families are harmonious or all families are safe. And just like in domestic violence or other fields, we must have our eyes wide open that we must support family caregiving, but we have to screen and not assume everything as well and figure out how to provide the right support. I think the caregiver stress issue is somewhat controversial. We don't want that to become an excuse for violence that's driven by power and control. I'm one of the old power and control wheel people. So how do we continue to provide support to keep the whole person supported, to keep their family supported, and what are the assessments and screening mechanisms and programs that take to put that in place? It's very important. Because, you know, I'm a talker. I talked to some family caregivers one time. I talked to them multiple times. 3 years ago, I was in Chicago, and I was talking to family caregivers, and this man was talking about caring for his partner, and he said, he's my sweetie, not my patient. So how do we provide family caregiving in a way that's not clinical, but supports the real need of the whole person?
Indeed, this photo that you have brought us, which is so enlightening, shows one of the challenges that we have. The family nature is changing. And we have here possibly a gay couple, and we have increasingly people that don't have children. Some of them, it's optional. And we are going to see cohorts of people with very different families from the families that they had before, either because they don't have children or because they are children with the social mobility and the geographical mobility and the global mobility I mentioned before, migration. Their children may be far away. In a country as big as the States or mine in Brazil, we don't have that family there. So often we pay lip services to family caregivers that don't exist, and we have to be very aware of the need to develop the policies that will cater for those different families that are living for longer and longer.
I'll certainly say that at least for those individuals who may have a diagnosis of Alzheimer's disease, there's a real effort afoot through the National Alzheimer's Project Act that President Obama signed into law in January 2011 to focus on not only developing a cure for the illness by 2025. That's the date that's put out there. But also to be supportive to the families and the caregivers of these individuals. Relative to the issue of families being continuously working there, a recent report has come out showing that there are millions and billions of dollars that are being basically spent by the sweat equity of the family members who are caring for individuals with the diagnosis of Alzheimer's disease. And so, yes, the family is very important. Yes, we are making an effort to be supportive. Again, the Administration for Community Living is taking the lead on those efforts. We're happy to say that some of the research that has come from NIA and NIH helps with that. We have one intervention in particular called REACH, and I won't remember what the acronym stands for, but it's basically a program that provides education and support to individuals who are caregivers of someone with Alzheimer's disease or other dementias. And it's been demonstrated to decrease the stress for that caregiver, to decrease the likelihood that the individual for whom they are caring gets placed in a long-term care facility. It's a very good intervention, and it's something that has been now disseminated through the Administration for Community Living System. It's being disseminated through the Department of Veterans Affairs, and there are other sorts of things like that that are underfoot. Not nearly probably as much as being put towards that fiscally as could be, but there are certainly efforts underway.
I just want to echo Dr. Kalash's question. What happens when there is no family caregiver? And demographically, that is going to happen a lot more.
Mm-hmm. I don't have an answer for that, Dr.
I think it's very important that we be very broad-minded in our concept of family. I mean, we could say family and friends, but they're really chosen families. And often when we think of family caregiving, we're thinking of the next generation. Many of the family caregivers are the partners and spouses of the older person themselves. So if we're broad in our concept of who family is and don't get very small-minded about it, then it does incorporate kind of the community. I mean, it really at some point becomes a communal activity, the community surrounding that person, that loves that person, that provides their primary support. That's who we need to provide support for.
And I will certainly say that we do have some experiments ongoing with communities of older women, for instance, who live in high-rise apartments in New York, who are serving as support to each other. And there's similar sorts of efforts in communities within the D.C. area. Other questions or comments?
We've had similar problems about family caregivers in the caregiving of schizophrenia over the years. Mm-hmm. And in many countries, it's 90% of schizophrenics live with their home. Now in America, it's much lower. A lot of them con to the street and our social services provide. But in the family caregiving element, there's certainly been efforts to, one, education and sort of monitor the family to see if they develop depression and something in the process of caring for the family. There's also examples where there's breaks where the family member with schizophrenia can go to the hospital for a couple of weeks just to give the family enough breaks so they can get a breather and kind of get their energy again to kind of take on the ongoing lifelong task of caring for a really seriously disabled person. I'm not sure if there are models there that might be applicable to the elder care situation.
I certainly am aware that as a VA physician, they had respite stays that allowed the frail veteran to stay either in the hospital or in a nursing home for a brief period of time to give the family, the caregivers, a break. And that was demonstrated to be a beneficial sort of thing in terms of preventing the need for a person to be permanently placed. I'm not clear still on Medicare rules to allow for that sort of thing, but those are things to be considered. Yeah.
Number have to go in permanent care.
Yeah.
But for time's sake, Jeff, it's okay. Thank you, Dr. Menard, and very much for being here with us today.